would now like to invite Dr. Keith Barton to give his talk on glaucoma tubes, do's and don'ts. Sir has a vast surgical experience in the tubes and has given great presentation on MIBs as well. So, thank you, sir.
Thanks very much, Mike, for setting the scene, because a lot of what I do is pretty risky. But then the risk of not doing it's even worse, which is why we do it in the first place. But a risk-averse surgeon's really no use to anybody. So there has to be a working. I can just yell. So, covering the do's and don'ts of tube surgery in 15 minutes is going to be a bunch of sound bites, or else I go at the right pace and give you some detail, and we just pull the plug when we run out of time, which I feel is probably the better option, because just to sit and give you a list of do's and don'ts without really the reason behind them, from my perspective, is just a total waste of time, I think. So, I mean, here they are anyway. Don't put in the wrong tube. Don't put the plate in the wrong place. Don't put the tube in the wrong place. Do check and adjust the drainage. And that kind of sums it up. Don't put in the wrong tube. Well, there are those who are at a high risk of chronic hypotony. We all know we're trying to get the pressure down. And when we put in tubes, we're trying to get the pressure down in people in whom it's quite hard to get the pressure down. Yet, there are some that if you do a trabeculectomy will fail completely. And if you put in a tube, they'll get chronic hypotony. Those tend to be, in my experience, JIA especially. Not so much these days because they're so much better treated, but I mean, Mike Coot's nodding, but when we trained the JIAs, correct me if I'm wrong, always came aphakic with pretty shot eyes. And if you put in even a single plate Maltino, they would get a chronic pressure of 3. So you have to be very careful. And if you put in a Barvelt, you're screwed. So those are the patients who are particularly risk. But now you can't, it's not one size fits all. Modern JIAs who've been aggressively treated with biologics and all the rest of it are not anything like as crashable. So it's hard to get it absolutely right. The other ones that, at least in the West now, chemical burns are pretty rare with all the employment safety legislation. But in the past, these often have badly damaged ciliary bodies as well. Multiple CPC, not just one CPC, those who've been kind of dioded to death and still have a high pressure, or severe ciliary body damage. And these are the ones in whom to consider a smaller plate. And I've raised some eyebrows every once in a while when I fish the last single plate Maltino off the shelf and shake the dust off it, and everyone's like, what's that? But some of these patients, it's still worth considering. People confuse those at a high risk of hypotony with those at a high risk of complications from hypotony. And I feel that very high myopes, aphakics, actually aren't at particular risk of hypotony, but they really get into big problems if you get it. So it's a slightly different thing, and Sturge-Weber as well. And these are the ones who don't necessarily need a smaller plate because they don't necessarily scar less. But if you don't get the drainage right, you'll be in big trouble, which is slightly different from those at high risk of hypotony that need a smaller plate. So that's my personal take on this, although a lot of my colleagues feel that aphakics and myopes are just higher risk of hypotony. I don't think they're quite the same thing. Don't put in a small plate just because the patient is small. Children scar more than adults, not less. All the pediatric implants out there are completely mislabeled. These are not for pediatrics. These are for people who are likely to get hypotony from low aqueous output. I've never seen a child that's got a low aqueous output unless they've had severe chronic arthritis, uveitis. Don't just put in a small plate because of lack of space. Lack of space is usually not associated with a low scarring potential. It's usually lack of space because there's a lot of scarring. So here's a patient that came to me, interestingly, referred from a colleague in Italy some time ago, and they had this tube which was draining rather well. And I had a bit of trouble convincing the patient that something needed to be done. So I stuck him on the video slit lamp and got a couple of colleagues to look, and they both went, and then the patient agreed to have surgery once they saw my colleague's reaction. The patient had quite a few, and this was the plate. So basically he had a buckle, so there wasn't much space, so they put in this miserable little, I don't know, I think it's an S3. Do you know, Sean? Is that it's a small pediatric amide valve. I'm not sure this is any use for anything. You know, it certainly don't put it in when there's no space, because it's not going to work, and if you're unlucky, you'll end up with what happened there. So I took it out and put it on a pole. You've got to make the space that you require, not go, oh my God, there's no space. So don't put the plate in the wrong place. Don't compromise in your placement technique because of obstacles. You know, aim to get the plate as far from the limbus as possible, ideally around 10 millimeters from the limbus. Although I would caution in, you know, I've got a non-ophthalmic who we had trouble finding the tube in the vitreous cavity. It was a pars-planted tube. And the ultrasonographer happened to mention, by the way, you know the plate sitting on top of the optic nerve. So this was a supratemporal plate that was on top of the optic nerve because it was a 15.3 millimeter eye. So, well, you know, I don't even know if that's an issue because we're not usually ultrasounding the non-ophthalmics after putting the tubes in. So maybe they were all sitting in the optic nerve and nobody noticed. Anyway, don't put the plate in the wrong place. Don't be put off by obstacles. This is a 44-year-old Indian lady, at least she was in 2007. High myope, uncontrolled open angle, glaucoma, pressure 28, slightly thin cornea, mean deviation minus 32, sort of average for my clinic, I think. Vision 618, retinal detachment surgery in India in 1997. Of course, the other eye had been enucleated at birth, and she actually got a sponge 360 degrees, which I'd never seen before because we always used those as radial plombs way back in the day. But anyway, that's what she had, and that was her field. And her husband said, you know, please don't let my wife go blind. And it's like, So anyway, in goes the Barvelt. And that's what you find sometimes with these sponges. And probably what I did there was unnecessary because I probably just cut a hole in the sponge, brought the tube through it and just left the plate behind. And you can always leave plates quite a long way back and you won't end up on the optic nerve with most of them. This is supratemporal. But in the end up, what I did was I stuck a scleral patch graft through the hole just to be safe and brought the plate forward. This was the other quadrant, which I looked at just out of curiosity, which had even less. In fact, it's almost just choroid underneath the sponge in that quadrant. So how did she do? Well, you know, you might say this is very risky in view of what Mike said. Well, she did phaco in 2011. The last time I checked her on the system was 2021, 13 years post-op. Still no eye in the other eye. Left, still 618, pressure 10 on lubricants. And this is what enthused me about tubes in these difficult cases over the years, is the amazing results you can get. Well, you could say this is one-off, but I mean, I can't spend the whole afternoon showing you 20 cases, but the reason that I've done buckled tubes so much over the years is because they actually work. Tube's a little bit anterior, they do migrate a little bit with time, cornea's still clear, and that's several years later. This was a couple of weeks ago. This patient had no space at all, and he had a buckle done in 2001, and I didn't think it was going to stop coming out. I think it's a 276, I'm not sure, correct me if I'm wrong there, but you know, I haven't seen one of these for a long time, but I don't think I've ever seen one circumferentially. You know, normally it's a segment with a band round, but the problem here was there was literally no space for anything. The patient needed a tube, so we took that out. Check underneath, the sclera was a little bit thin, but not catastrophically so. So there's space for a plate there. There was no space anywhere else for a plate. So what you then have to do is, the buccal capsule is not going to be big enough for a Barvelt or a Paul implant. So then you have to do a lot of exciting blind dissection, basically through a pool of blood, to open up the back of the capsule so you make space for the plate. You really have to do this and make space. You know, if you don't, you're going to end up putting in one of those tiny little amide valves that don't work or leak. So eventually the plate goes in. It's fine. And this was only 2 weeks ago, so I don't know how he's going to do. He's doing okay so far. This was a young woman during COVID who'd needed a tube and she's got Ehlers-Danlos. The other eye was no light perception because she got a spontaneous scleral rupture when she was putting in her contact lens. So I didn't want it rupturing when I was putting the tube in. And it's quite easy to take a piece of patch graft, if you have them available, and stick it over the thin area, glue it down with Tocil, and suture the plate to it. Okay, you might say, well, suturing a plate to a glued patch isn't very secure, but remember, if you've got a very big surface area of patch, a lot of surface area of contact, it's not going to move much, so you do get stability. And interestingly enough, there's still space under the muscles. Most of these plates are thin enough to still get in the right place. And 5 weeks post-op, you can see it. I went infranasally, I think, in this case, because it looked like the least dangerous area, basically. And all of these thin areas, you look around to see what's most easy to go. So this was another one. This lady had congenital scleromalacia, no rheumatoid. Unusually, most of my scleromalacias are rheumatoid. Again, you look for the least difficult quadrant, which happened to be down below. She had some sclera there. You open it up slowly and try not to. It was just choroid under parts of that thin area, which you'll see in a minute. And I had to beat a hasty retreat. So it didn't go there. You put down an underlay. Despite what I said earlier about pericardium, this was in 2017 when I was using pericardium, but you can use it as an underlay. Put the tube through it, and then put another overlay patch on top. So you can, despite the obstacles, you can get them in the right place, and they work. I tend to say don't make a small peritomy. Quite a few colleagues I see making quite small peritomies and then these deep relaxing incisions, which I really don't like. Make a big peritomy, get plenty of access, make it easy. Put the plate where it should go. My preferred quadrant's supratemporal, but you have to be flexible according to what's available, and that's about 11 millimeters in that case. I tend to use Tenon's traction sutures, but for 3 reasons. 1, they prolapse the globe. 2, they stop the sutures getting all tangled up when you're trying to suture the plate down. And occasionally, if you've got lashes all over the place, they keep the lashes away from the plate. So hopefully less contamination. But the point is that biocompatibility is related to micromovement in all types of devices. So I tend to I like the plate to be sutured down tightly to minimize micromovement, because hopefully that's going to limit encapsulation. And I use these diagonally opposed sutures, so one's pushing against the other, so the plate doesn't move. I do use mitomycin. This is more controversial. This is my single most un-American activity, I think, because I take it there's a lot of evidence out there that mito doesn't do anything, but that doesn't make any sense to me, and I deeply suspect that it doesn't do anything because you're not using very much of it. And if you're using mito, you really have to douse it in this situation. And people will say, well, you might get erosions, you might get this, you might get that. You don't. You would barely know afterwards that you've used any mito. In this case, the sponges have gone right on bare sclera. I wouldn't usually do that. You can either put them top of the plate to protect the sclera so at least less is getting in the eye, or what we traditionally did, which was Peng Cole's idea originally, was you get a Calazian clamp, put a couple of sponges in it, and then put them back. But don't put in, don't sprinkle it like holy water. It's not going to do anything. You need to really, that's 0.5 milligrams per mil for 5 minutes and 2 big sponges. And we virtually get no hypertensive phases, and we don't really get encapsulated blebs. So make the peritomy large enough, put the plate far back, secure it tightly to sclera, and I like the Tenon's traction sutures, and I do use mito, except in the uveitis where I think there's a risk of hypotony, or other people where there's a risk of hypotony. Don't put the tube in the wrong place. So they used to tell me that after 10 years all the corneas fail. That's when I started doing tubes. So here's somebody who clearly has indestructible endothelium, because this patient had double plate Multino at some point in the 1990s, and an infratemporal Barvelt in 2002, and this video was 20 years later. This was 20 years after the Barvelt and 20-something years after the Multino, and the cornea is as clear as a whistle. So either this patient has indestructible endothelium or something doesn't fit. So here's severe primary angle closure, arguably at the highest risk of endothelial cell failure, because they have very high pressures to start with, which damages endothelium, and very small eyes. There's more likelihood of corneal mechanical damage. Yet 20 years later, the cornea is still clear. Here's another one. This is a bilaterally aphakic uveitic Barvelt, 2001, 2002. 20 years later, the corneas are clear. And these are isolated examples, which isn't evidence of anything, but it just proves that, at least that for some people, the corneas are clear. So we looked at this prospectively in a bunch of Barvelts for over 5 years, looking at pressure, flare, endothelial cell count, and peripheral endothelial cell density over the tube. And I was convinced that there would be no endothelial cell loss because all my tubes are flat on the iris. And no matter what people tell you, a tube being flat on the iris does not cause uveitis. Half of these patients are uveitic, and I will always put them on the iris. You get a little depigmentation, you might get some peaking, but that's far better than corneal endothelial cell loss. So at 5 years, there was 37% central endothelial reduction, density reduction, 50% over the tube, which sounds pretty awful. If you look at the tube position, the tube insertion position, in relation to Schwalbe's line and the peripheral cornea, there's a dramatic difference. If the tube was completely behind Schwalbe's line at the entry site, you're getting 24.7% endothelial cell loss at 5 years. If the tube is straddling Schwalbe's line, where the supposedly non-existent progenitor cells are, it's double that. So typically we always said there's no progenitor cells, endothelium doesn't replicate, but apparently it does, there are some. It just doesn't replicate a lot. And apparently if you're straddling Schwalbe's line, it's bad news. Ironically, it was slightly better if the tube was actually in the cornea, which I wouldn't advise. But you can see that by knocking the tube, putting the entry site right against the iris, you're halving the endothelial cell loss rate. So it's not the tip, well, it's not just the tip that's important, but the entry site. So that partly explains, this Barvelt, as you can see, is flat on the iris. I'm not so sure about the Multino, but anyway, after 20 odd years, the cornea is clear. So you're still getting quite a lot of endothelial cell loss. Why do many not decompensate? So, okay, say your average tube patient doesn't have 2,600 endothelial cells to start with, maybe just 2,000. After 5 years, hi. I thought you'd come to pull a plug that I'd run out of time.
Keith,
After 5 years, at 25% loss, you're down to 1,500. After 10 years, you're down to 1,125. After 15 years, you're down to 843. After 20 years, you're down to 632. 25 years, you failed. Hang on, I just get to the point here. Nobody rang a bell. If you've had 50% loss when you're putting it straddling Schwalbe's line, you're failing at 10 years. So what I'm doing isn't preventing failure by putting it against the iris. I'm delaying it from 10 years to 15 years approximately, in theory. And I think that's the difference. So by careful tube positioning and having the endothelial cell loss rate, the corneal failure doesn't occur at 10 years, it's occurring at 25 years. Why not put it in the sulcus? This is Ying Han's paper at roughly the same time as ours in ophthalmology. Interestingly, her sulcus endothelial cell loss rate was actually not any better than ours when it was flat on the iris. In fact, it was slightly worse, but what I would say is it seems that you can minimize endothelial cell loss by having it flat on the iris or in the sulcus, but it doesn't look like you can get rid of it completely. And we measured flare in all these patients, and half of them are uveitic. And it's always said that inflammation is a factor, but we did not find any association with flare. So there it is. Anyway, I don't think they all fail after 10 years, and I think I ought to stop there because I've got about another hour of this. Thank you very much.
Thank you so much for a wonderful presentation. I think we all learned a lot, and I think you are right. I think it's maybe it's the movement of the tube also, because I have a guy right that it's going through the cornea, but for now almost 17 years the cornea is absolutely clear.
Yeah, I mean, I'm sure movement has something to do with it. Certainly for erosion, I'm sure movement has something to do with it. But I've seen tubes that when you move the eye, they piston in and out, and I'm sure it must be causing some attrition. And what we forget, I think, is that the eye is not a stationary object. Neither the optic nerve nor the cornea, it's moving all the time.
Keith, those are great tips for the ones where you have a scleral buckle. I'll tell you what I do. I just put a FP7 over the buckle.
Yeah.
Have you ever tried?
That's interesting. So, yeah, well, this really wasn't supposed to be a talk about buckles, and I didn't go in detail. But I've typically put bar velts over buckles, because if the buckle's low, the bar velt's a lot thinner than an FP7, so it goes over the top easily. It's interesting you say that, because I didn't think you could get an FP7 over it, because basically a bar velt plus a buckle is about the same height as an FP7 without the buckle. So it must be pretty high.
You could also connect a tube to the buckle itself, the sheath.
Sorry?
You could also connect a tube to the, like a socket kind of
but sockets were pretty crude. You could do that, but I'd much rather have proper control. I have to say, taking the buckle out and putting the plate in is a last resort that I only do in the eyes where there really is no other option. So I typically do is what Shan says, is put the plate on top of the buckle.
Yeah. Thank you, Keith. I think that's a wonderful talk and